Today we will discuss about the sciatic nerve. It are clinical aspects are very important. Okay, you will get patients of sciatica. So sciatic nerve, this is lumbar plexus. Sciatic nerve is branch from the lumbar plexus. Okay, lumbosacral plexus mainly. So sciatic nerve is the thickest nerve in the body and it is the largest branch of sacral plexus. Okay, so these are forming together the sacral plexus. L4, L5, S1, S2, S3. Okay, so it is largest branch of sacral plexus. Acha, femoral nerve was branch of the lumbar plexus. Okay, our sciatic nerve is branch of sacral plexus. So it begins in the pelvic cavity and exits the cavity through the greater sciatic notch, then runs in the gluteal region and the back of thigh and finally terminates by dividing into tibial and common peroneal nerve in the popliteal fossa. Okay, you have seen the sciatic nerve in gluteal region and back of thigh. And width of the nerve, very thick nerve, okay. It is given in your OSPI question. So width of the nerve is 1.5 to 2 centimeter. How it is formed? Formation, it has two components, tibial and common peroneal parts. Okay, so tibial part is formed by the anterior division of ventral primary rami of L4, L5, S1, S2, S3. All these root values are present. Next is common peroneal compartment. It is formed by posterior divisions. Here tibial you can see anterior division, or common peroneal posterior division of ventral primary rami of L4, L5, S1, S2. Okay. So root value is L4, L5, S1, S2, S3 together. So root value is important. In your OSPI you will be asked about root value. Okay. Next is the extent. Sciatic nerve passes through the following regions. First the pelvis, then gluteal region and back of thigh up to the superior angle of the popliteal fossa. Okay. Here it is dividing into these two components. Sometimes there are variations. Okay. High division also occurs, dividing itself within the pelvic cavity or dividing in the gluteal region, dividing in the back of thigh. All these can occur, different variations. So what is the extent of the sciatic nerve? Sciatic nerve passes through these regions up to the superior angle of popliteal fossa, and these are the relations in the different region. In the pelvis, the sciatic nerve in the pelvis lies on the anterior surface of piriformis muscle under cover of its fossa. And in the gluteal region, it enters the gluteal region through the greater sciatic foramen below the piriformis muscle. And superficial relations are these: gluteus maximus, long head of biceps femoris. And deep relations are from superior to inferior. Bed of the sciatic nerve is formed by body of ischium, tendon of obturator internus with superior and inferior gemelli together forming the tricipital tendon. Next is quadratus femoris and the adductor magnus. These are deep relations of the sciatic nerve. In the medial relation, inferior gluteal nerve and the vessels. Okay. Next, in the thigh, superficial relations are long head of biceps femoris. It crosses the nerve from medial to lateral side. And deep relation is adductor magnus. Medially lies the semimembranosus, semitendinosus. Okay, and laterally biceps femoris in the middle of the thigh. So these are the different relations of the sciatic nerve at different levels. See here, this is the location. So it lies deep to the gluteus maximus, okay, and the deep fossa. And here it is, these muscles are forming the floor. Here this is piriformis. These are the tricipital tendon, obturator internus with superior inferior gemelli. This is quadratus femoris and here is adductor magnus. Okay, and medial relation semitendinosus, semimembranosus, laterally long head of the biceps femoris. Okay, so these are the relations of the nerve. It's a schematic presentation of the nerve. Okay, and you can see the long head of biceps femoris is crossing the nerve from medial to laterally, and it lies in superficial relation along with gluteus maximus above. Okay, understood the relations? So branches, this is schematic diagram of sciatic nerve. Okay, so these two components are joining here. This is tibial, this is common peroneal, forming the sciatic nerve, then extending downward at the superior angle of the popliteal fossa, dividing into these two components. Tibial, green one is tibial, this is common peroneal, and these are their supplying areas. Okay, so the tibial component, it is supplying the hamstring group of muscles. Okay, semitendinosus, semimembranosus, long head of biceps femoris, and hamstring part of adductor magnus. These two have other nerve supply also. Okay, here short head of biceps femoris is supplied by the common peroneal, and other part of adductor magnus supplied by the obturator nerve. Okay, and so common peroneal component only supplying the short head of biceps femoris. It is dividing at the superior angle of the popliteal fossa, then it is going to the lateral angle near the neck of the fibula, then it is dividing into two branches, superficial and deep peroneal nerve, and those are giving branches to the leg muscles. Okay, leg and foot. So what are the branches of sciatic nerve? Articular branch for the hip joint, muscular branch, tibial component is giving semitendinosus, semimembranosus, long head of biceps femoris, ischial head of adductor magnus, and common peroneal part is supplying the short head of biceps femoris. Okay, and these two are the terminal branch, tibial nerve, common peroneal nerve. So intramuscular injection, these are some clinical aspects, comes in your explain why question. Okay, important explain why kintu. Why the intramuscular injection in the gluteal region should be given in upper outer quadrant, and it is given to save the sciatic nerve. Okay, ওই বাচ্চাদের যে টিকা দেওয়া হয় ওগুলো সব গ্লুটিয়াল রিজনে দেওয়া হয় ম্যাক্সিমাম, সো ইট ইজ গিভেন ইন দ্য আপার আউটার কোয়াড্রান্ট. ওকে, also in adult patient you need to give some injection in the gluteal region. Okay, during cesarean section or other different operation. So next, this sciatic nerve block. To block the, here this intramuscular injection is given in upper lateral region to prevent injury to the sciatic nerve, to prevent the paralysis of sciatic nerve due to the needle stick injury. Okay, so this is main reason. This comes as explained why. Another is sciatic nerve block. To block the sensation conveyed by the sciatic nerve, anesthetic agent is injected 4 to 5 centimeter below the midpoint of line posterior superior iliac spine to greater trochanter. Okay, so at 4 to 5 centimeter below the midpoint of this line, you have to put the injection. Okay, to block the sciatic nerve. Next is sleeping foot. What is sleeping foot? On sitting on a hard surface, sciatic nerve gets compressed against the femur. Okay, so and it results in numbness and loss of sensation in the feet and legs, and it is called sleeping foot. Okay, if you sit for a long period in the hard surface, that's why it is avoided to sit a long time over the hard surface. Should use some soft cushions or like this. Okay, so and sensation resumes back within a few minutes. This is temporary paralysis, so sensation regains back. Next is Baker's cyst or popliteal cyst. You have seen diagram of popliteal cyst. It is a fluid collection behind the knee, and it is the posterior herniation and cyst of synovial membrane of the knee joint. Baker's cyst. This is the diagram. Why? So this is gluteal region. We are dividing with these two lines into 4 quadrants. So you should give the injection in the upper outer quadrant because the nerve is not crossing this quadrant. Rest of the 3 quadrants, you can see nerve is passing through rest of the all the 3 quadrants. Okay, so Why? What is piriformis syndrome, and it is related to this intramuscular injection. So to save the sciatic nerve during intramuscular injection, upper outer quadrant of gluteal region is most commonly used quadrant for injection to prevent injury to the sciatic nerve, as it has outward convex course between the following two points. Point A, here is point A, point B. Okay, it has outward convex course between these 2 points. First point is 2.5 centimeter lateral to the midpoint of the line joining the posterior superior iliac spine and ischial tuberosity. See this line, posterior superior iliac spine and ischial tuberosity, midpoint of these two, this point A, and point B is midpoint of the line joining greater trochanter and ischial tuberosity, greater trochanter and ischial tuberosity, its midline. So this point is point B. So in between these two, the nerve has a outward convex course. So injections are preferably given in the gluteus medius muscle. Okay, here gluteus medius is present and gluteus maximus is going like this. So here you will not get the maximus. Okay, this is also asked in your viva. So injection is given in which muscle? Okay, so remember gluteus medius, not maximus. See how you can place the fingers like this and give the injection here. Okay. Here sciatic nerve block is being given. See where the injection have been put. To block the sensation conveyed by sciatic nerve, anesthetic agent is injected 4 to 5 centimeter below the midpoint of line joining posterior superior iliac spine and greater trochanter. This is midpoint. From the midpoint you go downward 4 to 5 cm below. Okay. Here is the location of sciatic nerve. You push the anesthetic agent here, it will block the nerve. Okay. For any case of any surgery in the lower limb, you can block the sciatic nerve. Okay. So next is what is piriformis syndrome. This is comes in your short note. Piriformis syndrome. Okay, very important. What is piriformis syndrome? This is a symptom is mainly pain in buttock, commonly occurs in ice skaters, cyclists, rock climbers because they use the gluteal muscle vigorously, and it causes compression of sciatic nerve by hypertrophied or bulky piriformis muscle or spasm of piriformis muscle during these sports activities. Yes. Sciatic nerve compression. Yes. Piriformis syndrome is mainly compression of sciatic nerve. Okay. Compression due to hypertrophied or bulky piriformis muscle or due to spasm of the muscle. Okay. Because it is lying in close relation to the muscle, forming the floor of the muscle, anterior relation to the nerve. Okay. Yes, cramps, be due to cramps, muscle cramp. This spasm means muscle cramp. Okay. Hypertrophy means muscle become more bulky, so it will occupy more space. So there is less space for the nerve, there will be compression. Okay. And symptom হচ্ছে pain in the buttock mainly, and commonly occurs, you remember, ice skaters, cyclists, rock climbers. Okay. Next is sciatica. This is very common condition. It is a clinical condition that manifests with shooting pain along the distribution of sciatic nerve and its branches. Okay. So these are the distribution. Sensory loss occurs in this area supplied by sciatic nerve. Pain usually begins in the gluteal region, spreads over the back of thigh, lateral side of the leg, and the dorsum of the foot. Okay. What are the causes of the sciatica? Herniation of the prolapse disc. This is intervertebral disc. It is prolapsing anteriorly, prolapsing posteriorly and entering into the vertebral canal through which the nerve roots of sciatic nerves are passing. and they are being compressed and it will cause pain. Okay, compression of sciatic nerve is occurring due to prolapse of the intervertebral disc. So what is sciatica? Herniation of intervertebral disc in the lumbar or sacral regions, also occurs in pregnancy, piriformis syndrome due to compression of sciatic nerve within the piriformis. And pathology is compression of these nerve roots L4, L5, S1, or spinal cord. Okay, what is the treatment? Treatment is based on the cause. Most of the cases recover in a few weeks to months, and it may require rest, physical exercise, and NSAID, non-steroidal anti-inflammatory drugs. Okay. In severe cases, discectomy may be required. In case of prolapse of disc, you have to do discectomy. Okay, prolapse part you have to remove. Discectomy is removal of the intervertebral disc. Okay, but it has some complications. So, in less severe cases, you should not do the discectomy. So, sciatic nerve is the thickest nerve in our body. It can be easily identified in the gluteal region. Under the cover of gluteus maximus, it is lying. In the thigh, it is crossed by the long head of biceps femoris. And the variation in the level of terminal division of sciatic nerve is very common, and it may have high termination even in the pelvic cavity itself. I have discussed the variation. In the pelvic cavity or in gluteal region or in back of thigh, the division can occur. All the muscular branches of sciatic nerve arise from its medial side, except for the short head of biceps femoris. That arises from the lateral side. Hence, surgically, the lateral side of the sciatic nerve is sepside. Okay. What is arteria nervi ischiadici? It is a small artery that accompanies the sciatic nerve, and it is a branch of inferior gluteal artery, and it is a part of axial artery of the lower limb. Okay. So, axial artery of lower limb is a embryological structure represented in the adult life by arteria comitans nervi ischiadici, part of popliteal artery above the popliteus muscle, and distal part of peroneal artery and part of plantar arch. Okay, all these are forming the embryological axial artery of the lower limb. Okay, these are important for your MCQs. Okay, so next we are going to the two divisions in details. First the tibial nerve, next we will discuss the common peroneal nerve. So tibial nerve is the major nerve that supplies the posterior compartment of the leg. This is the tibial nerve. Root value is ventral primary rami of L4, L5, S1, S2, S3. Okay. Course, it is the largest terminal branch of the sciatic nerve, runs vertically downward in the popliteal fossa from its superior to the inferior angle, and it crosses superficially the popliteal vessels from lateral to medial side, and the lower down continues in the posterior compartment of the leg. Okay, here in the popliteal fossa, here in the back of the leg. Okay, posterior compartment of leg. What are the branches? This is schematic presentation of the tibial nerve. These are the branches given in the popliteal fossa, and these branches are given in the leg. And here are the two terminal branches, medial lateral plantar nerve, division occurring in the sole of the foot. Okay. So muscular branches, tibial nerve supplies the medial and lateral head of gastrocnemius. Here, plantar is soleus and popliteus. Popliteus and the soleus. And cutaneous branches are sural nerve that supplies the skin of lower half of back of leg. This is sural nerve, and the lateral border of the foot till the tip of little toe. Okay. Next is articular branches. Articular branches are superior medial genicular, middle genicular, inferior medial genicular. Okay, these are going towards the knee joint, supplying the knee joint. And the nerve to popliteus winds around the lower border of the popliteus muscle and supplies this muscle from its deeper or anterior aspect. And all the muscular branches of tibial nerve arise from its lateral side except the nerve to medial head of gastrocnemius that arises from its medial side. Hence, the lateral side of tibial nerve is surgically unsafe or dangerous. This is important. Explain why. Why the lateral side is surgically unsafe. Okay. Whereas the medial side is surgically safe. No branch is coming out from medial side. Next is middle genicular nerve. It pierces the oblique popliteal ligament along with middle genicular artery and supplies the interior of the knee joint, one of the genicular branch. Next is sural nerve. This is cutaneous nerve. It leaves the popliteal fossa by piercing the deep fossa at the inferior angle of the fossa, and it supplies the skin of lower half of the back of the leg at the lateral border of the foot till the little toe. This is the extent of sural nerve. Okay. Sural nerve, if present, you will see during leg dissection. So this is the summary of the tibial nerve. Beginning, it is the larger terminal branch of sciatic nerve. Root value is L4, L5, S1, S2, S3. How it terminates? It runs vertically downward from superior to inferior angle of the popliteal fossa, crosses the popliteal artery and vein from lateral to medial superficially, and branches are these: muscular branch to two heads of the gastrocnemius, plantaris, soleus, popliteus, other muscles of back of leg. Cutaneous branch is sural nerve, articular branch superior medial genicular, middle genicular, inferior medial genicular nerves. Okay, these are articular branch to knee joint. Next, another clinical aspect is tarsal tunnel syndrome. Okay, important for your Viva and MCQ. Handy, you have read carpal tunnel syndrome. There is tarsal tunnel syndrome. It is a condition where the tibial nerve is compressed within the tarsal tunnel, and this may occur due to osteoarthritis or trauma and result in paresthesia of the ankle and sole. Okay. So we have completed the tibial nerve. Okay. Next there is common peroneal nerve. Paresthesia means numbness. You cannot feel. Sensory loss occurs. Okay. Numbness. No. Here complete blockage occurring. Na? So that's why completely lost can occur. Treatment to vitamin B complex or others রিলিজ অফ দ্য কম্প্রেশন করতে হবে আগে, তারপরে ওইভাবে যার যেরকম কজ ফর দ্য ডিজিজ সেইভাবে ট্রিটমেন্ট। ওকে, নেক্সট হচ্ছে common peroneal nerve. Okay, this is schematic diagram of common peroneal nerve. So it is the smaller terminal branch of sciatic nerve. Its root value is dorsal division of ventral rami of L4, L5, S1, S2. Okay. So, and what is the course? It begins at superior angle of popliteal fossa under cover of long head of biceps femoris, runs downward and laterally along the medial border of biceps femoris towards the lateral angle of popliteal fossa, and it winds around the neck of fibula and pierces the peroneus longus muscle and finally divides into superficial and deep peroneal nerves. These are the terminal divisions, superficial, deep. And you can see it is giving branches from the lateral side, short head of biceps femoris. Next, this is given in the thigh, okay, upper lower part of the thigh, and these are the genicular branches: superior lateral genicular, lateral cutaneous nerve of thigh, cutaneous branch, inferior lateral genicular, another cutaneous branch is sural communicating. Okay, so these are the branches, cutaneous branches. These two are the cutaneous branch, lateral cutaneous nerve of the calf and sural communicating nerve. And articular branches are three: superior lateral genicular, inferior lateral genicular, or recurrent genicular. Okay, understood? These are the branches. Branches you remember for each of the nerves, branches and root value. Okay. So, common peroneal nerve does not give muscular branch in the popliteal fossa. Lateral cutaneous nerve of calf or lateral sural nerve supplies the skin on the upper part of lateral side of the leg. Sural communicating nerve arises opposite to the head of fibula and crosses superficially the lateral head of gastrocnemius to join the sural nerve. Superior and inferior lateral genicular nerves accompany the arteries of the same nerve. Okay. Then recurrent genicular nerve arises just before the division of common peroneal nerve and it ascends anterior to the knee joint to supply the tibialis anterior muscle and the knee joint. Okay. So this is the summarization. Begins as terminal branch of sciatic nerve. Root value is L4, L5, S1, S2. This is the course. It runs from superior to lateral angle of the popliteal fossa, deep to the biceps femoris, and winds around the neck of the fibula. Okay. Next is the branches. Branches are cutaneous branches, lateral cutaneous nerve of calf, and the sural communicating nerve. And articular branches are superior lateral genicular, inferior lateral genicular, and recurrent genicular nerve. Okay. Next, we are going to this two terminal division. First, we will discuss superficial peroneal nerve and then the deep peroneal nerve. Deep peroneal you have seen in the anterior aspect of the leg dissection, and superficial peroneal also you have seen lateral part of the leg where peroneus longus, peroneus brevis was lying. Okay, so deep peroneal nerve is nerve of anterior compartment of leg, and superficial peroneal is nerve of lateral compartment of the leg. So superficial peroneal nerve is nerve of lateral compartment of the leg. Okay, see this is the lateral compartment now. It is supplying the peroneus longus, peroneus brevis, and this green colored portion it is giving cutaneous supply. It is dividing into two branch in the foot, lateral and medial branch, and supplying the whole area of the foot. Except this web space, first web space, and on the two sides of the foot, okay, on the dorsal aspect. So, beginning of the superficial peroneal nerve, it is the smaller terminal branch of common peroneal nerve, and it is given at the neck of the fibula in the substance of peroneus longus muscle. Okay. What is the course? It begins on the lateral side of neck of fibula in the substance of peroneus longus, and then it pierces the peroneus longus and runs downward between the peroneus longus and peroneus brevis, and later between the extensor digitorum longus and peroneus brevis. And at the junction of upper 2/3 and lower 1/3 of the leg, the superficial peroneal nerve pierces the deep fossa and divides into medial and lateral terminal branches. Okay, cutaneous branch. These are the different branches and their distribution. Muscular branches to these two muscles, peroneus longus, peroneus brevis. Cutaneous branches to lower 1/3 of the leg, lateral side of the leg, lower 1/3, and greater part of the dorsum of the foot, except the areas supplied by the saphenous nerve, sural nerve, deep peroneal nerve, and plantar nerves. Okay, plantar nerve is supplying the sole. Here is the saphenous nerve, this is sural nerve, and this is deep peroneal nerve. Okay, so excepting all these areas, rest of the areas supplied by branch from superficial peroneal. So terminal branches, the medial branch divides into two digital branches. One for the medial side of big toe, here medial branch, lateral branch. Medial branch is giving two terminal branches. One branch for medial side of great toe, other branch divides into two digital branch supplying sides of this second and third toe. Other for adjoining sides of second and third toe. Okay. Next, lateral branch. This is lateral branch. It divides into two digital branches. One for adjoining sides of third and fourth toe. Other for adjoining sides of fourth and fifth toe. Okay. Like the palm. Palm में supply মনে আছে তোদের? Radial nerve, median nerve, এখানেও same ওইভাবেই হচ্ছে। Next, we are going to some clinical aspect. Injury to the superficial peroneal nerve. It may occur due to trauma or nerve compression in the lateral compartment syndrome. Okay, lead to lateral compartment syndrome, and it results in following inabilities: loss of eversion of foot due to paralysis of peroneus longus and peroneus brevis, and loss of sensation over its supplying area, that is lower one third of the leg, most of the dorsum of the foot except at first webspace, which is supplied by deep peroneal nerve, and dorsal aspect of all the toes supplied by deep peroneal nerve, superficial peroneal nerve. Okay. So this is summarization of the superficial peroneal nerve. It begins as terminal branch of common peroneal nerve, begins at neck of fibula. Root value is L5S1. Okay, root value you remember. Course, it pierces the peroneus longus, runs downward between the peroneus longus and brevis, and later between the extensor digitorum longus and peroneus brevis. Then pierces the deep fossa, divides into medial and lateral terminal branches. Okay. Okay, next, these are the branches. Muscular branch is given to peroneus longus and brevis, cutaneous branch to lower one third of lateral side of leg, greater part of dorsum of the foot, except areas supplied by saphenous nerve, sural nerve, deep peroneal nerve, and the plantar nerves. Okay. Next, we are going to deep peroneal nerve. So, we have completed the superficial peroneal nerve. Okay. Deep peroneal nerve is nerve of the anterior compartment of the leg and the dorsum of the foot. It comes in your long question, deep peroneal. Okay. And its clinical aspect is very important, foot drop. Okay. So, root value is L4, L5, S1, S2. সুপারফিশিয়াল পেরোনিয়াল নার্ভ L5S1 ছিল, এখানে চারটেই আছে। ওকে, all the component of the common peroneal. Beginning, see this one is deep peroneal nerve. Deep peroneal nerve is one of the terminal branch of common peroneal nerve, begins at the neck of fibula under cover of peroneus longus muscle. Here. Now we are going to the course and relations of deep peroneal. So deep peroneal nerve begins on the lateral side of neck of fibula, and it pierces the anterior intermuscular septum to enter into the anterior compartment of the leg. It pierces the extensor digitorum longus and descends along with the anterior tibial artery. See here, descends along with anterior tibial artery, and in the middle third of the leg, and this here it is piercing through the extensor digitorum longus. Okay, and then in the middle third of the leg, nerve tries to cross the artery anteriorly. Here the nerve is trying to cross the artery anteriorly but hesitates and remains on the lateral side of the artery. Hence, the deep peroneal nerve is also referred to as Nervus Hesitans. Okay, this comes in or explained why deep peroneal nerve is called Nervus Hesitans. Okay, because it is trying to cross the artery from lateral to medial side in the middle one third of the leg, but finally it is lying on the lateral aspect of the artery. Okay, so that's why, as if the nerve is hesitating to cross the artery, that's why it is called Nervus Hesitans. Okay. Huh? তিনটাই লিখতে হবে। Next is termination. how it terminates. The deep peroneal nerve ends on the dorsum of the foot in front of ankle by dividing into medial and lateral terminal branches. Okay. Next, we are going to the branches of the deep peroneal nerve. Muscular branch or terminal branch. Muscular branch for all four muscles of anterior compartment of leg, that is tibialis anterior, extensor digitorum longus, extensor hallucis longus and the peroneus tertius. যে এখানে দেখ tibialis anterior, extensor digitorum longus, extensor hallucis longus, okay, and the peroneus tertius. All these are supplied by deep peroneal nerve. And it is then dividing into two terminal branches, lateral terminal branch and medial terminal branch. এই ওয়ার্ড দুটো ভুল লেখা আছে, অল্টারনেট হবে, okay. Medial will be lateral, lateral will be medial. So you can see the lateral terminal branch, it runs under cover of extensor digitorum brevis. This small muscle lying over the foot is the extensor digitorum brevis. It runs underneath this extensor digitorum brevis and ends in a pseudoganglion. Here is a dilatation you can see. This is pseudoganglion formation and it supplies the extensor digitorum brevis and the tarsal and metatarsal joints. Okay, so this is supplying area of lateral terminal branch. And the medial terminal branch, you can see it is runs forward and supplies the skin of first interdigital cleft, supplying adjacent areas of first and second two. Okay. So this is the summarization of deep peroneal nerve. First is the beginning. It is the terminal branch of common peroneal nerve, begins at the neck of fibula and root value is L4, L5, S1, S2. Course, it pierces the anterior intermuscular septum and the extensor digitorum longus and descends on the lateral side of anterior tibial artery and it hesitates to cross the artery, hence called the nervus hesitans. Okay, and these are the branches. Muscular branch are tibialis anterior, extensor digitorum longus, extensor hallucis longus, peroneus tertius, okay, in the anterior leg muscles. And terminal branch, lateral branch is supplying this muscle, extensor digitorum brevis, and medial branch is going to supply first interdigital cleft. Okay. And these are some fact. Deep peroneal nerve corresponds to the posterior interosseous nerve of the forearm. Okay, posterior interosseous nerve of forearm also has a pseudoganglion. Okay, these are important for your viva. Which nerves are having the pseudoganglion? Posterior interosseous nerve is also having one pseudoganglion. Okay, what are the nerves which have pseudoganglions? Okay, this is another lateral terminal branch of deep peroneal nerve. This is also having pseudoganglion. And identify the structure of anterior compartment of the leg at the level of extensor retinaculum and trace them upward to identify the nerve. Okay, in front of the ankle joint you can clearly identify the nerve, deep peroneal nerve. Then you have to trace the nerve upward, okay, to identify it in the leg. Okay. Next, the clinical aspects. Okay, এটাও নেক্সট ক্লাসটাও কিন্তু হয়ে যাচ্ছে একসাথে, হ্যাঁ। Okay, so injury to the deep peroneal nerve, it occurs due to trauma, peripheral neuritis in leprosy or entrapment neuropathy of deep peroneal nerve due to overuse of muscle of the anterior compartment of leg, and it results in damage to the deep peroneal nerve. And it results in these symptoms. There will be paralysis of the muscles of anterior compartment of leg causing foot drop. Okay, why foot drop occurs in deep peroneal nerve palsy? This is important, explain why. Okay, or part of the long question. Deep peroneal nerve comes in your long question, prepare as a long question. and this occurs due to unopposed action of the plantar flexor muscle. Plantar flexor muscles are those back of the leg muscles, the gastrocnemius, soleus, all this. Okay, so these actions are not lost, but anterior compartment muscles actions are lost due to paralysis of deep peroneal nerve. So there will be foot drop. Okay, and there also will be sensory loss confined to the first interdigital cleft, which was supplied by those medial terminal branch. And this is also important, this comes in your short note: nerve supply of the dorsum of the foot. Okay, so the cutaneous nerves of dorsum of the foot are this. First is superficial peroneal nerve, it is branch of common peroneal nerve. It supplies most of the dorsum of the foot except the skin of the cleft between the first and second toe. Okay, deep peroneal nerve, also a branch of common peroneal, supplies the skin of the cleft between first and second toe. Okay, sural nerve, branch of tibial nerve, supplies the lateral margin of the dorsum of the foot and the little toe. Okay, so along the lateral aspect, sural nerve. And saphenous nerve, it is a branch of femoral nerve. We have got in the femoral triangle. It supplies the medial margin of dorsum of the foot up to the head of the first metatarsal. Okay, so these four nerves are supplying the dorsum of the foot. And you practice this diagram. This diagram is important. So this area is supplied by superficial peroneal nerve along with its branches. This interdigital cleft by the deep peroneal nerve, along the medial margin saphenous nerve, along the lateral margin sural nerve. Okay, understood? So these are the four nerves and their supplying area. Okay, any further queries? Okay, so you prepare superficial peroneal nerve and deep peroneal nerve. Deep peroneal nerve is long question, superficial as short note. Okay, and prepare the clinical aspects as explained by foot drop and sciatic nerve is a clinical aspect. ওগুলো খুব important. Sciatica, sciatic nerve block, why injection is given in upper lateral quadrant, all this, and sciatic nerve itself come as a long question. Okay.